This is a lecture that I presented at the BDA Annual Conference in May of 2016. And it's an overview lecture covering the materials and techniques for the aesthetic and functional rehabilitation of tooth surface loss. So it should be considered that it is an overview lecture and certainly not a comprehensive lecture. With the courses that I run, we can often easily spend 1 or 2 days considering these range of topics that we're going to consider over the next 45 minutes or so. What are we going to look at during this lecture? Well, during this overview lecture, we're going to look at the prevalence and the etiology of tooth surface loss. And we're going to look at the general restorative treatment strategies. I'm not really going to be focusing on prevention during this lecture. So do bear in mind that prevention is obviously a big part of treating these cases. We're going to look at the role of splints, and then we're going to look at a range of cases. We're going to look at using the Dahl appliance technique in localized anterior tooth surface loss. We're then going to look at more generalized tooth surface loss and the role of composite, the role of crowns, and the role of onlays in rehabilitating these patients. We'll also look briefly at the role of the overlay or onlay denture for more severe cases. And then we'll finish with a comprehensive case which demonstrates a joint orthodontic approach, and it's a high-risk case which also demonstrates the use of particular materials, whether we use zirconia, whether we use layered zirconia, or whether we use e.max to rehabilitate the case. And it also focuses in on what the orthodontist can help the restorative dentist with as well. What's the prevalence of tooth surface loss? Well, there's 2 papers here really. The first of them is the Adult Dental Health Survey, and it's only been the last 2 adult dental health surveys that have really focused in on tooth surface loss. Well, what they found was that there was a significant increase of 10% in the recording of tooth surface loss. And this is particularly in the younger age groups. And the summary was that this was of particular concern because it's in the younger age groups, this tooth surface loss is only going to get worse. Then the Salas et al. Study, this is actually a systematic review and meta-regression analysis of a range of studies. But certainly within the Western world, the overall prevalence of tooth surface loss is approximately 30% of the population. So what these studies show is that at the present time, it's a significant problem. And what the studies suggest is that it's actually going to become a more significant problem. So as things progress over the next few years and decades, tooth surface loss, I think, is going to be the next major restorative challenge. Periodontal disease, being largely genetic, will remain stable at current levels. In terms of caries, this is likely to stabilize and drop. But tooth surface loss or destruction of tooth tissue due to things such as erosion, etc., is going to increase. And it's going to represent a significant restorative challenge. And it's still, in the same way as caries, destroying or removing tooth structure. So it should be noted that this is more difficult to restore often than dental caries. So what are the causes or the etiology of tooth surface loss? Well, in my own clinical practice, I tend to find that there is a multifactorial etiology. There is often 1 or 2 factors that predominate, but there can be more going on than that. The biggest cause, without a doubt, is chemical erosion. And this either comes from intrinsic or extrinsic acid. Intrinsic acid we'll look at later. We'll look at a bulimic patient later who essentially self-induces vomiting. And we'll also look at a gastroesophageal reflux disorder patient who brings up the acid at night. In addition to that, I think really extrinsic acids are the biggest problem. And in particular, things such as carbonated drinks would be one of the biggest causes. Parafunction, at least 20% of the population undertake grinding at night, and approximately 10% day stress clench. Now, we won't go into that in too much detail today, but that is probably an underestimation of how much parafunction and clenching is going on. And if you combine parafunction with chemical erosion, it will actually make the situation far worse. Malocclusions can contribute as well. The principal malocclusions would be somebody who has an edge-to-edge class 3 occlusion, and they're much more prone to wearing the incisor teeth. Patients with deep overbites and also cross bites, they're all more predisposed to anterior tooth surface loss. A lack of posterior support can be a problem. So if you're losing molar teeth at an early age, then you're putting more forces through the anterior teeth, and at this point these teeth can start to wear. The anterior or restricted envelope I've spoken about on numerous occasions, and I won't cover this today, but again this is an important recognised pattern of tooth surface loss. As patients age, it's inevitable with some patients that the canine ramps will wear, and so the canine wears down, and essentially what happens is that the teeth behind the canine or in front of the canine come into group function. Now, this is particularly damaging for anterior teeth if they don't have a protective guidance, and then the anterior teeth can wear. It tends to be less of an issue when posterior teeth come into the bite, as the load tends to be more widely spread. But do bear in mind that forces at the back of the mouth are greater, and so there can be wear of the back teeth as well. And then we have attrition, which is tooth on tooth, or really tooth versus restorative material. And the restorative material, which is our most abrasive in terms of causing attrition, would really be Feldspathic porcelains. And then there is abrasion, and this is often from smoking type toothpastes or brushing technique using a hard scrub. And with toothpaste, it's really worth going on the internet, and what you want to look at is the RDA, and that is the relative dentine abrasivity. And a toothpaste with anything over 70 RDA would be considered to be abrasive. And a lot of toothpastes on the market are abrasive. And then finally, this is often less of an issue, but I will demonstrate this with a case later. The posterior interference, where the patient has to either posture forwards or laterally or both to miss a posterior interference. And then this will lead you to have more anterior tooth surface loss. So what is the overview of our restorative strategies? Well, I've published back on this in 2014 in the International Journal of Advanced Clinical Dentistry. And really the restorative treatment strategies are varied. The first thing we have to look at, and I won't really be covering this again in this lecture, is do we need to open up the occlusal vertical dimension? And for a great number of tooth wear cases, an increase in the occlusal vertical dimension will be required. So what are our treatment strategies? Prevention has to be the mainstay. So we have to look at prevention first of all. Then moving into more interventional treatments. Splints can be useful, so we will cover splints briefly today. And then we have a whole range of materials, composites, crowns or onlays. And this will very much vary depending on the degree of the tooth surface loss. The more minimal, the more composite is indicated. And then often with posterior teeth, onlays will be indicated. And then with anterior teeth, where we have aesthetic problems, crowns are often indicated. But do bear in mind that we're often using shell zirconia or shell e.max now. So this kind of dated concept of crowns such as metal ceramic, which are destructive, is really long gone. I would tend to think of the crowns that I do these days really as full coverage veneers. So what else do we need to look at? Well, when it's very severe, we need to look at the use of overlay or onlay dentures. And at this point, these can be combined with simple tooth-based precision attachments to help the retention of the denture. Dahl appliance is particularly useful for localized anterior tooth surface loss. And then if there's missing teeth, we may also be considering factors such as dental implants, particularly to increase the number of occluding units and so providing posterior support. And also in terms of implants, not only can they do this, they can also be for cosmetic reasons as well. And we also need to consider a multidisciplinary approach. You can see that there are a number of techniques that we need to master to be able to effectively treat tooth surface loss. There is no right or wrong answer to which strategy should be used. It varies for each individual patient, and indeed it varies for each individual tooth. So it's not uncommon for me to have a case where I'll be using composite, I'll be using crowns, I'll be using implants, I'll be using onlays, all in the same case. And you may also have to look at the use of orthodontics, particularly where there's malocclusions, and also factors such as surgical crown lengthening when we have compromised tooth structure or height. We'll focus on splints first of all. I'm going to leave out general prevention, but I want to focus on splints. And essentially within dentistry there are 4 types of splints. We have the soft bite guard, we have the free plane or flat plane splint, we have the restorative or Michigan splint, and then the anterior disengagement splint. And each of these have their own indications and their own uses. So the soft bite guard, I think, is a very useful splint to use. And the soft bite guard is essentially a protective shock absorber. So if you have a patient who has parafunction or stress clenching, then this will actually protect the teeth from wear. So it's a very useful splint for that. It should be noted though that it has been reported that approximately 50% of patients who parafunction, if you give them a soft bite guard, it will make the parafunction worse. However, in some respects this is not a major issue because it's quite useful co-diagnostically. I find it very valuable to be able to hold a splint out for a patient and show the wear facets or the perforations in the splint. This very much brings their problem and their disease to life. And if this simple soft splint works, then it's fine. If it doesn't, then it's very easy to make a case to the patient if they're grinding through it. Very easy to make a case that we should progress on to a hard splint. But really think of the soft bite guard as a protective shock absorber. It's often made in the upper arch, and then essentially you have point contact with each of the lower teeth. The next level of splint up would be a hard splint. And so who would a hard splint be useful for? Certainly any parafunctional patient who grinds through the soft bite guard. And this is quite a simple splint. And it is important that bruxist patients do have splints. We know that splints don't cure bruxism, they don't significantly reduce it, they are really simply protective. And so in this case here you can see that this is a hard acrylic splint, and it is a very simple, flat, hard acrylic splint. Unlike the soft bite guard, it's more of a permissive splint. It allows the lower dentition to grind around, and these are often made in the upper arch. We try and achieve point contact on it, and then when the patient grinds around, rather than tooth on tooth or porcelain on tooth, they grind onto the splint. In lateral excursion, the splint is marked, and we try and eliminate significant lateral excursion on the molar teeth, but it is a relatively simple splint. The next type of splint I'll cover very briefly, but this is generally called the restorative or Michigan splint. If it's made in the lower arch, it's often called the Tanner appliance. Now, I used to make a lot of these splints, and some of the assumption on making these splints was that the splints would cure or reduce the bruxism. Now we know that isn't the case, then essentially we make fewer of these splints. However, there are features to these splints which may be desirable in patients who have muscle pain or muscle symptoms. And what these splints do is they basically are like the flat plane splint, but they have canine ramps. Now, there is good evidence from a kind of classic study by Manns and also by Williamson that when you have these canine guidance ramps on the splints, you have less muscular activity. The muscles potentially relax more. Won't stop the muscular activity, but it may be useful in patients who have muscle pain and quite severe problems. In addition to that, these splints, apart from reducing symptoms, may be useful in patients where you think they have a bad occlusion, and the bad occlusion may be contributing to the wear. So if you think they have a bad occlusion, these splints, because they're going to give you an ideal occlusion, will help with that. Now, there's a lot more to the restorative splint because it requires a centric relation record, and they are more time consuming to adjust and fit. So there is a much more to this splint than we will cover in this lecture. The final kind of splint, which is also can be used as an occlusal deprogrammer, is the anterior disengagement splint. Now, it does go by a number of different names, but essentially what it is just a flat anterior bite platform. So here's a picture of the ones that I mainly use. It's collected around the teeth. It has occlusally approaching clasps on the molars, although Adam's cribs will do nicely. And you can see that it has a flat platform that really extends along the upper central incisor teeth. This, more recently, has been used for stress clenchers. So I do think it's a particularly useful splint for people who suffer from tension headache, etc. And certainly the American Dental Association have recently approved this for the treatment of headache, and the Hornbrook article covers that. Again, there is the study by Becker and the study by Manns that these anterior bite stops significantly reduce muscle activity. So if you've got somebody who's stressed, who's clenching, this could help relax the muscles. We do need to be careful with these types of splints though, because they are not full coverage, and I have seen several reports and certainly several cases myself where these splints have been used and teeth have over-erupted. So they are a short-term measure and not for full-time use. That should be considered. But they are a valuable asset. That essentially covers a very quick overview of the role of splints. And then the first type of tooth wear I'd like to look at is the localized anterior tooth surface loss. And previously I've published on this back in 2014 in the Journal of Private Dentistry. It has a very typical wear pattern. It essentially affects the upper teeth, and it's the upper anterior teeth. And generally this is caused by induced vomiting. So it is patients who would have bulimia, it is patients who have anorexia nervosa. I've also seen it in cases where patients have had very bad morning sickness and are maybe vomiting 2 or 3 times a day. They can cause this same wear. As the patient vomits, the acids come forward and predominantly affect the palatal surface of the upper anterior teeth. As the patient vomits, the tongue spreads, and so the lower teeth tend to be more spared. And what is typical of this is there will be an absence of wear on the back teeth. So look at the wear. You can see that it is on the lower anteriors, very much incisal, but also a little bit on the upper buccal third. And on the palatal, it is very much the whole palatal surface of the upper anteriors. It extends beyond the intercuspal position. If it only goes to the intercuspal position, or the incisive intercuspal position, it would be more of a restricted envelope. We can see with this patient here that she had presented because the veneers on the central incisors that had been in place for several years suddenly started debonding. And this was due to the collapse in the OVD at the front of the mouth and also the over-eruption and increasing overbite. And this is what precipitated seeking treatment. In addition to this, you can see that she had a carious fracture or a fracture of the upper premolar tooth, which was going to be replaced with an implant. And the Dahl appliance, first reports really of this type of appliance go back to the late 60s. And then there are a number of studies by Dahl and effectively demonstrating this appliance, which is really a simple linked orthodontic bite razor. Since then, the landmark study by Goth and Setchell really looked at approximately 100 of these appliances, and they showed that these appliances were safe and highly effective. So we have one here, so we have a DNAR mounting on the right on the articulator. The pin has been raised, and then what I generally use is laboratory composite with a slight platform on it. And we're opening up the bite enough here to provide room for replacement veneers. And the veneers are going to be replaced with anterior crowns. So the veneers will be replaced with anterior crowns. What you'll find is that you only need to open up the space enough to make room for the crowns. You can use a conventional cobalt chrome dial, but these are very much more difficult to adjust, less aesthetic, and so composite in terms of laboratory composite is very adequate for these type of things. So what happens is a Facebook record is taken, a DNAR mounting, and then we open up the pin enough for the lab to be able to make the appliance. Now it's laboratory composite, so it would need to be approximately at least 1 millimeter thick, and then you can see how it opens up space at the back of the mouth. These teeth will then over-erupt into a more stable occlusion, and then once you have the space, you can go ahead with your crowns. Now it is possible just to crown the teeth, so you can just go ahead and crown the teeth and use that as your Dahl appliance, but as the crowns won't be linked, if you get your occlusion slightly wrong, you can cause fracture or damage to the crowns, or you may cause unwanted orthodontic movement. So it is much a safer approach to actually go for a conventional Dahl first of all. And then the Dahl was dentine bonded into place for approximately 9 months, and that shows you how much reduction of the overbite we have anteriorly, and how the posteriors have over-erupted into a nice interdigitation posteriorly. During that stage, the veneers completely failed, and so the referring dentist actually placed some direct composite veneers on the front teeth. We are now in a position where we can go ahead and replace the veneers on the centrals, and as we have space open on the palatal, we can undertake palatal reduction. Now, the palatal reduction will only involve removal of the Dahl, no tooth destruction. The upper laterals are in standing, and the patient didn't like the aesthetics of these, and so what we did here was we undertook full coverage crowns on the centrals but also on the laterals, and because we were widening out the arch form, there was virtually no reduction on the lateral incisors. The canines, you can see, have the Dahl in place, and this was literally sectioned anterior to the canines, polished over, and then these were left essentially as composite long-term shims. So once the space was created, we went through what is my standard restorative treatment of a diagnostic wax-up to assess the changes to be made in terms of aesthetics. We then had an index of the wax-up in terms of a silicon index, and then this forms our preparation or prep-through guide. So a silicon impression is taken of the upper wax-up. This is then filled full of a material such as Luxatemp, but any bisacryl resin will do, and then this is placed over the teeth, and then we can cut depth grooves in there. And so what we have on the right hand side is ultra conservative preparations. The lateral incisor preparations still predominantly, virtually exclusively in enamel, and on the central incisors really just removing the old veneers. We are eliminating undercut, and we are cutting a very minimal finishing line, a minimal chamfer, and then approximately 1.5 mm reduction. So these are not your classic conventional destructive metal ceramic crowns. These are ultra conservative crowns that make use of modern all ceramic materials. And these then would be suitable for either e.max or zirconia type crowns. Things have moved on a lot in terms of crown preparation, and these are on the top right. These are alumina oxide Procera crown preps undertaken about 15 years ago. And the preps on the lower right are preps I undertook about 4 years ago for e.max. And look at the difference. Very heavy aggressive preps, very minimal preservative preps. And that's because we have much better ceramic materials now than we did 10 or 15 years ago. And so what are we doing? Well, we're minimizing tooth removal. That has to be good. It means that we have a stronger tooth, a tooth that is less likely to fracture. We also will have less incidence of pulp death. Don't forget, approximately 1 in 10 crowns that you prepare, the pulp will die at some point. And hopefully this will eliminate that pulp death because we're undertaking much more minimal preparations. Here are the final e.max crowns, and in this case we undertook e.max crowns with a small amount of Feldspathic porcelain on top. We could use press-only e.max crowns, which are stronger and still have very, very good aesthetics. But the overbite is reduced, and we have restored our canine guidance, and so we have a protected occlusion. And this case I published in Dentistry magazine in 2016, back in April. Well, let's look at a different type of case. Let's look at a case where we have generalized tooth surface loss. And this would effectively be your GERD or GORD patient, our gastroesophageal reflux disorder patient. And these are patients who bring up acid at night. And again, this case is published back in the International Journal of Advanced Clinical Dentistry in 2014. And this is a case we're going to treat with composite, crowns, implants, and also onlays. So multiple restorative treatment strategies in the same case. And don't forget, GERD patients or gourd patients bring up the acid at night. They can be symptom-free, but they can have problems such as halitosis, metallic taste, heartburn, retrosternal pain. All of these could be indicators. And risk factors include obesity, alcohol, fatty diet, and there's a number of predisposing factors, things such as smoking as well. And so we have a general pattern of tooth loss. It's on the occlusal surfaces, it's on the incisal surfaces, it's on the buccal, it's on the lingual. And so we also had a posterior interference here. The upper left 8 had over-erupted, so that was also deflecting the occlusion, which could have contributed as well. And so if we first look at the lower arch, which is more simple to treat, this kind of case is absolutely crying out for just direct bonded composite. And generally I would do this freehand over approximately 1 hour to restore the whole lower arch. So it protects the remaining tooth tissue, it protects the exposed dentine. However, tooth wear is challenging. And if we look at one of the major studies by Smales and Berkeley, this actually shows quite a high failure rate. So our indirect restorations, the failure rate over 10 years is about 25%, relatively high. That's probably because a large proportion of these patients are bruxists who would really benefit from splints. But look at the survival, or concentrate on the failure of direct composite. It's quite a high failure rate, about 40%. And the number of studies that are out there show that the most common problems we get are either chipping, fracture, or actual full loss of the composite restoration. In addition to that, staining of the composite is a big problem as well. So one of the challenges that we've been looking at within the teaching institute that I run and the clinical practice that I run is how can we overcome this? And what has been a revolution in terms of treating tooth wear is the BioClear matrix system and the BioClear technique. So this is not just a matrix system, but it's a whole technique for predictably undertaking composite restorations. And it's very applicable to tooth wear cases. Well, what's going to help with the success with this technique? There's no doubt if you have enamel rims present, this will help. But what do we use in this technique? The first thing we use is particle abrasion. And there are a number of units out there. There is a BioClear blaster from Optident, and also companies such as Prestige Dental. They market products such as the Aero Etcher, the DentaPrep, Cojet. They're all quite similar. So particle abrasion removes debris, it removes biofilm, it removes smear layer. Then we etch and bond, and the underlying part of the technique is that we use heated monolithic composite. So we're not messing about with little increments and adding bits and patching bits up. This is when they all start chipping, they start debonding, they start fracturing, they start staining. What you do with these matrices is you actually, with these anatomical matrices, pretty much form the whole restoration in one go. Now this gives you an excess, and then rather than incrementally building up, you cut back the excess and then polish it. And the 3 studies at the bottom really starting to have this movement going forwards that we should really not be layering our composites anymore. We should be following this technique, using particle abrasion, but using monolithic composite. The other thing that we've found within our clinical practice is that if you keep the composites approximately 2 mm thick, then they are much less likely to break. Now this may involve in certain instances actually removal of tooth structure. The anatomic matrices allow you to build this up in one go, and then you basically take them over the whole buccal surface, and then you place your finishing line at the gingival margin. We then undertake gross reduction, and to improve stain resistance, we undertake polishing, essentially with what is termed the jazz polisher from SS White, and this gives you a highly polished composite. And what we have found with this technique is reduced fractures, reduced staining, and because of the anatomical matrix, we get excellent marginal adaptation and we get no overhangs. And this whole system can be used for diastema closure, black triangles, building up composite crowns, building up composite veneers, and we also use it posteriorly for inlays and onlays in direct composite, and then MO or DO composites as well. So apart from the restorative courses that I run, the certificate course and the more advanced course, we also run independent courses on the BioClear system as well. And here's two studies of numerous studies that back up the efficacy of particle abrasion. And that shows you the DentaPrep, and it also shows you the BioClear Blaster. And the DentaPrep is virtually the same as the Aero Etcher, which is currently available from Prestige Dental. And so in a similar way to the last case, we would then undertake a diagnostic wax-up. Now there was a CR record undertaken here, but I don't want to go into the CR record during this presentation. But we have a diagnostic wax-up, we have a putty index of our diagnostic wax-up, and then this is applied to the teeth. Small amount of occlusal adjustment is undertaken, and so we have the whole upper arch temporized in a bisacryl Luxatemp resin. We can then use this anteriorly for our prep through guide, and posteriorly we're going to leave the acrylic in place, as this maintains our CR record and it also maintains the occlusal vertical dimension. We then have standard anterior e.max crowns, and these again very minimal crown preparations. You saw the preparations earlier when we contrasted them with the previous preps we used to do. And so these are ultra conservative preparations but with a highly aesthetic result. These are then fitted, and at the time of fit we can then go ahead and prep the posterior teeth. Posteriorly, what is the most tooth preservative thing we can do? We will use press only e.max. And the press only e.max is applicable for anybody except for parafunction patients. So be careful with the e.max in parafunction patients. These are the only ones I've had fail. And you can see what we have is a simple butt joint rounded preparation. And then we have our MOD onlay e.max restoration. Highly aesthetic and highly durable. And then that completes the case. You can see the lower arch composite. You can see upper anteriorly, crowns but with virtually no preparation. And then you can see the onlays on the back teeth. Now the implants were provided for occlusal stability. We found that the last standing teeth in the lower arch, if we hadn't placed the implants, would have effectively been in danger of over-erupting as had previously happened. And again, I've published on generalised tooth surface loss both in Dentistry magazine and also the Journal of Private Dentistry. Well, what do we do when it's more severe? There comes a time when you can't build things back up and you essentially need to knock it down. This is a GERD patient again to some degree, but also a patient who lost the crowns on his back teeth. And when the situation becomes worse, we are really looking at over or onlay dentures for the patient. We're really looking at a removable option for the patient. And don't forget that overdentures, they're not second-class treatment. When you look at studies, and a recent sort of study shows that patients rate satisfaction with overdentures as high as implant-supported dentures. So these represent a highly predictable form of treatment. They're very retentive, they're very stable if made correctly. And so what this provides for the patient is an excellent cosmetic result. Not only dentally, but also facially. We're restoring the OVD, we're making the patient look younger. We're restoring a youthful smile to the patient. And so we spend a lot of time on my restorative course going through overdentures and onlay dentures. For those of you who want further reading, the Journal of Private Dentistry, I cover overdentures to some degree. And then there's an older dental update article from Hemmings et al., which covers the use of partial dentures for tooth wear in great detail, and it's an excellent article. When we have the roots left, and this is a highly compromised case, a patient who has several contraindications to implants, we do have simple precision attachments, and for those of you involved in implant dentistry, you may be familiar with this attachment here, which is the locator attachment. Well, this actually can be used on natural teeth, and you undertake a post prep, and then they cast on the locator component. And then in the denture, there is a light pinky red locator clip. And then these locator attachments are excellent for stabilizing dentures. So to conclude, let's look at a more complicated case. This is a patient who has parafunction, he has a class 3 malocclusion, he has tooth wear, he has an aging smile, he has aesthetic problems. You can see that he has an upper missing lateral incisor. And so sometimes these cases need a more comprehensive approach, and he really needs an orthodontic approach. And this has been an area that I've focused in on for nearly 2 decades now, is the role of orthodontics pre-restoratively. It's something that has become kind of quite trendy of late due to 6-month smiles, etc. But really I've been doing this kind of treatment and liaising with the orthodontist for over 20 years. Now in this case we're actually using comprehensive orthodontics, and the comprehensive orthodontics was undertaken by Dr. Peter Huntley in Solihull. But in certain instances, for less severe cases, we can use shorter term orthodontics as well. Well, what is the orthodontist trying to do for the restorative dentist here? Well, he's increasing the OVD. He's opening up the space for our anterior restorations. He's creating a space for the upper right tooth to be replaced. He's getting rid of the cant. He's correcting the midline discrepancy. Numerous things that the orthodontist is doing here. Prior to the orthodontics, this gentleman did require treatment. He actually required surgical crown lengthening, so you need to be able to undertake procedures such as this to be able to treat tooth wear effectively. And then that is our post-orthodontic occlusion. And the orthodontist has done a fantastic job in giving us restorative space, opening up the space on the upper right. Everything has been done very, very nicely. Midline correction, cant correction. And now we're in a situation where we can undertake an implant upper right too. In the end, we actually undertook a bridge for the patient because the 1 and the 3 required crowns. And then we are going to restore the anteriors with crowns. So what can we use for crowns? Well, e.max, you can see from the studies here, very predictable. However, e.max for bridges, less predictable. So currently I wouldn't recommend e.max bridges. This gentleman elected not to have an implant upper right too, so this left us with a difficult situation. We wanted to undertake a bridge, but I didn't want to do metal ceramic because it's too destructive. e.max is too unpredictable. Layered zirconia bridges are prone to the Feldspathic chipping off, so what we undertook in this patient was mill and stain zirconia. So it is zirconia with no Feldspathic on it at all. And as you can see from the preparations and the crowns on the lower right particularly, that these are shell minimal crowns. So we're undertaking crowns on the teeth, but with really ultra conservative preparation, but using a very strong material. And so here are our ultra conservative preparations and then our final crown and bridge. Now it should be borne in mind that this is far less aesthetic than e.max. However, for patients who will accept this compromise in aesthetics, but the preservation of tooth structure and the preservation of the strong tooth, this represents a good form of treatment. So that provides what is just really an overview of the prevalence and the etiology, and then the restorative treatment strategies for the treatment of tooth surface loss. And I hope you found that valuable. Thank you for your attention.